Our next presenter is Professor Christopher Leung, Department Chairperson and Clinical Professor in the Department of Ophthalmology at the University of Hong Kong, and an awardee of the Ophthalmologist Power List 100. He will discuss Hong Kong Eye Survey, what population-based data reveals about disease burden and service gaps in Hong Kong. Please welcome Professor Christopher Leung.
Thank you very much for the opportunity to present some of the challenges we face in Hong Kong. Medical care and eye care delivery services in Hong Kong are largely provided by the government. And can I move forward? Thank you. And we face challenges because we don't have enough ophthalmologists in Hong Kong. We have about 360 ophthalmologists together with about 100 trainees serving a population of 7.4 million. It's huge workload. And it's no surprise when you look at some of the online data we post regularly, we notice that the wait time for a patient to see an ophthalmologist sometimes can be more than 2 years. And we have 7 clusters in Hong Kong, and each cluster serves their own local population. Some clusters are better, some clusters are worse. But overall, patients, when they need to see an eye doctor, they need to see a general practitioner to get an appointment, and then they wait for another 2 years if it is not urgent. For urgent cases, obviously, it would be faster. And for semi-urgent cases, typically within 1 month, urgent cases in days. If you are diagnosed with cataract, and then you have to wait perhaps. Now it's better because we have recent policy address asking ophthalmologists in Hong Kong in the government setting to push up the output rate. But we're talking about half a year to a year wait time. So to understand better what burdens we are facing, we conducted the Hong Kong Eye Survey, which represents perhaps the most comprehensive ophthalmic epidemiological study conducted in Hong Kong to date. And it aims to address the needs in Hong Kong ophthalmic landscape. So this study, this survey, has 4 different sites set up, both in the district health center, as well as in community center, as well as in some eye clinics. Over the past 6 years, we have examined more than 20,000 individuals aged 50 years or above. 11,000 plus, these were individuals we invited them to participate in the program. So we are collecting some population-based data. And then 14,000 plus, they are community-based screening. These are the demographics, very much comparable to the known Hong Kong demographics. And what we aim to achieve here is to identify the disease burden and survey gaps in Hong Kong. And second, I think what we need to do is to identify new ways, new approaches to help patients in Hong Kong to provide better eye care. This survey is also unique in the sense that it integrated a lot of cutting-edge technologies, different types of OCT, and different types of advanced algorithm. We included, for example, anterior segment OCT, posterior segment OCT, in addition to the conventional fundus camera. So we have every individual having these images taken. Some of these individuals, some of our participants, they also receive other varieties. Some of them have dry eye exam, a very detailed analysis of the OCTA images. We perform gonioscopy. We are trying to check whether examination or screening of angle closure with anterior segment OCT is relevant. And we also take blood. So some of this population, we will be able to perform whole genome sequencing, which is in collaboration with the Hong Kong Genome Institute to get some insights into how DNA, how genomics influence the presence of eye diseases in Hong Kong. These are some pictures captured on site. We have optometrists checking trial lens and presenting visual acuity. We have measured the intraocular pressure, OCT exams, a variety of eye tests. Analysis are still ongoing. I just give you some highlights over here. We found more than a quarter of our residents having mild visual impairment. They have visual acuity worse than 20/40, but better than 2200. Not surprising, but what we found was that this number dropped down to 11% after a spectacle correction. So a lot of our residents, they are not aware of the fact that they are not either wearing spectacle correction to improve vision, or the spectacles they are wearing are just not to the degree they need to get them the most optimum vision. Again, not surprising, cataract and refractive errors are the two major causes of visual disability. And we also included some new elements. We are using a technology we developed in Hong Kong. We call this retinal nerve fiber optical texture analysis, which allow us to visualize the individual axonal fiber bundles, giving us a better position to decide whether one has or has not glaucoma. We are also incorporating AI as a tool to help our eye care professionals to show where the abnormality is. We didn't provide visual field testing on site because it is difficult. Patients, participants, they don't like it. But we also have a kind of AI display to visualize, to help us visualize what type of visual field damages a glaucoma patient might have. In this case, we see an optic disc photograph. If you are looking at even with specialist assessment, you may wonder whether this eye has early changes of glaucoma. We see some rim loss, but with the AI tool, with rotor, we're able to clearly see this is actually a normal eye. We don't see any axonal fiber bundle abnormalities. On the other hand, this individual may be dismissed because the visual acuity is good, fundus is okay, and optic disc looks normal. But when we look at the rotor representation, we clearly appreciate our infratemporal retinal nerve fiber bundle defects. So here it is not the case of normal eye. And this is surprising. We found more than 10% of our individuals, now these are the population data, more than 10% of these individuals having retinal nerve fiber defects, and about 7% of them can be attributed to glaucoma. Now, we're using a definition of glaucoma by including both the rotor examination and the optic disc evaluation. So you need to have both retinal nerve fiber defects as well as corresponding rim loss in order to call this to be glaucoma. So this is pretty unexpected because we see about 5% of individuals having retinal nerve fiber bundle loss without having glaucoma. So we would like to push the initiative forward. We were recently awarded with $5 million to engineer a new paradigm which we can set up this OCT technology with AI tools at the front line, at the district health center, at the general outpatient clinic to screen and examine individuals, refer to our specialist eye clinic. For those with doubts, any eye disabling diseases, those with refractive errors, those with dry eyes, they can be handled at the district health center, they can be handled at the general outpatient clinic. Those with eye diseases, glaucoma, age-related macular degeneration, diseases that are potentially irreversible, they can be referred early to our clinic for management. The primary outcome measure we would like to achieve is to reduce the current wait time for more than 2 years to less than 2 months. So we really hope to introduce the idea of community eye care program in Hong Kong to really help relieve the burden of patient load in our specialist clinic. With that, I will stop there and thank you for the opportunity to present our findings.